Hello everyone, I'm Liang Xiaojin from Shanghai Jiaotong University School of Medicine. Today I'm going to talk about cystic fibrosis in my PBL talk show. Before I start my presentation, I want to emphasize that I use clinical key student and complete anatomy as my main resources to prepare for this presentation. There are numerous and exclusive materials including books, images, videos, and articles that are accessible. So make sure to check this out. Okay, let's begin with our clinical case. You are a doctor in emergency department. A 3-year-old female presents with 1 week of cough, purulent sputum production, dyspnea, and fever. The parents state that she has already had pneumonia 3 times in the past 2 years, and the girl also had a history of chronic daily cough, a pale, loose, greasy, voluminous, foul-smelling stool, and she also had a poor weight gain despite a great appetite. What is your first impression of this patient, and what can you interpret from the history? My interpretation of the history is that the chief complaint of the patient is a recurrent respiratory infection accompanied by chronic cough, styria, and signs of malabsorption. And let's move on. The vital signs of the patient are notable for a temperature of 38 degrees Celsius, blood pressure of 90/50, heart rate of 110 beats per minute, respiratory rate of 38 per minute, and 92% oxygen saturation on room air. The physical examination demonstrates a thin, malnourished kid with mild respiratory distress, and the pulmonary examination shows a diffuse bilateral valves and subcostal retractions. The pulmonary function test shows a decreased forced expiratory volume in 1 second, forced vital capacity ratio. The sweat chloride test shows at 81 millimole per liter, which is apparently above normal range given. So, based on the information above, what is the most likely diagnosis of the patient? Here's the answer. The triad of fatty diarrhea, recurrent pulmonary infections, failure to thrive, and a sweat chloride test that larger than 60 millimole per liter suggests cystic fibrosis as the underlying cause. There are a few questions that I'm going to discuss in the following slide. First, what is cystic fibrosis, how to diagnose it, and how to treat it. The incidence of cystic fibrosis is 1 in 2,500 live births. The major characteristics include persistent pulmonary infection, pancreatic insufficiency, elevated sweat chloride levels, and the median survival time is 47 years old. Cystic fibrosis is an autosomal recessive disorder caused by a mutation in the CFTR gene on chromosome 7, which impaired post-translational processing of cystic fibrosis transmembrane conductance regulator protein. Physiologically, CFTR encodes an ATP-gated chloride channel that secretes chloride in the lungs and GI tract and absorbs chloride in the sweat glands. The net result of genetic mutation is the alteration in airway secretion, which become thickened, viscous secretion in the bronchi, biliary tract, pancreas, intestine, and reproductive system. Cystic fibrosis affects several body systems, as we mentioned before, and the clinical manifestation gradually develop over time. The most common initial symptoms of cystic fibrosis is meconium ileus, which refers to neonatal bowel obstruction of the distal ileum due to abnormally thick and impacted feces. The patient typically presents with bilious vomiting and abdominal distension. The abdominal X-ray would demonstrate multiple air fluid levels due to intestinal obstruction. Pulmonary disease remains the leading cause of morbidity and mortality in patients with cystic fibrosis. The pulmonary manifestation of cystic fibrosis is bronchiectasis, which presents and deteriorates throughout the disease. Bronchiectasis presents with chronic productive cough that lasts months to years with large amount of sputum production. The CT scan shows the dilated bronchi with thickened walls. Recurrent pulmonary infections arise when bronchiectasis exacerbates. Eventually, progressive respiratory failure ensures and lung transplantation is necessary. Pancreatic insufficiency is another presentation of cystic fibrosis, which causes diarrhea, malabsorption, and secondary diabetes mellitus due to insufficient pancreatic enzymes and hormone production. The diagnosis criteria of cystic fibrosis required clinical symptoms consist with cystic fibrosis in at least one organ system, or a positive newborn screen, or having a sibling with cystic fibrosis, and elevated sweat chloride test larger than 60 millimole per liter, or a presence of 2 disease-causing mutation in CFTR gene, or an abdominal nasal potential difference test. There's no definitive cure for cystic fibrosis, but a range of treatment that can help to control the symptoms, prevent and reduce complications, and makes the condition easier to live with. The treatment of cystic fibrosis-associated lung disease include airway clearance therapies, bronchodilators, mucolytics, prevention and treatment of the infection, supplemental oxygen, and anti-inflammatory therapy. Other management include additional sodium chloride intake, high energy diet, pancreatic enzyme supplements, and oral supplementation of fat-soluble vitamin. The CFTR modulator are a new class of drug that's designed to correct the malfunctioning protein made by the CFTR gene. However, this drug is only viable to those patients with a specific gene mutation or deletion. And it wraps up my presentation. Thank you for listening, and I hope you guys enjoy this video.